Greetings and welcome to Module 7 of the 2021 Geneva Foundation for Medical Education and Research e-course on adolescent sexual and reproductive health and rights in the Eastern Mediterranean region. My name is Marina Plesons. I work with the WHO Department of Sexual and Reproductive Health and Research in Geneva, Switzerland, and I'm really pleased to share with you the global segment of the presentation for Module 7 on violence against women and girls, prevention, support, and care. Before I get started, I'd like to thank and acknowledge the contributions of two of my colleagues, Dr. Chandramouli and Dr. Avni Amin, for their contributions to this module. As usual, we'll get started with a few key definitions of the topic of the module. Gender-based violence is defined as violence directed towards a woman because she is a woman, or violence that affects women disproportionately. Violence against women is defined as any act of gender-based violence that results in or is likely to result in physical, sexual, or psychological harm or suffering to women. Intimate partner violence is defined as behavior by a current or former intimate partner that causes physical, sexual, or psychological harm. And finally, sexual violence is defined as any sexual act, attempt to obtain a sexual act, or other act directed against a person's sexuality using coercion by any person regardless of their relationship to the victim. Next, let's discuss a few points of rationale for addressing gender-based violence against adolescents. The first point is that gender-based violence against adolescents is an important problem. 2013 estimates suggest that among ever-partnered girls aged 15 to 19 years, the lifetime prevalence of experiencing intimate partner violence was 29%. And likewise, the prevalence of child sexual abuse worldwide is estimated to be approximately 18% for girls and 8% for boys. Now, updated estimates for the first of those figures that I mentioned are expected to be released on the 9th of March. Unfortunately, that's just a bit too late to be included in this module, but we really encourage you to look for that when they are released by the WHO. The key message, though, that will emerge from those is that evidence suggests that violence against adolescents is still unacceptably high in regions around the world. The second point is that gender-based violence against adolescents has major health and social consequences. It increases girls' risk of unintended pregnancies, induced abortion, which is often unsafe, the acquisition of HIV and STIs in some settings, adverse mental health outcomes, and gender-based violence is a risk factor for unhealthy behavior during adolescence and adulthood. Continuing with the rationale for addressing gender-based violence against adolescents are a few additional points. The third point is that gender-based violence prevention, support, and care programs have been shown to be effective for adolescents. Parenting support programs, school-based dating violence prevention programs, and community-based interventions to build equitable gender norms and attitudes in boys and girls have been shown to be effective at preventing violence against adolescent girls. Effective programs incorporate multi-sectoral and multi-level action. They foster intersectoral coordination. They use longer-term investments that repeat exposure to ideas in different settings over time. And they place gender power interplay at the core of the content. And finally, they respond to those who experience violence with empathy and in a timely manner. The last point, though, is that despite all of this, laws and policies, prevention strategies and their implementation, and access to high-quality care and support services need attention. In short, there's much to be done in this area. Next, let's discuss a few of the key human rights obligations with regard to gender-based violence, prevention, support, and care for adolescents. The first point is that states are obliged to prevent and respond to violence against women and girls, and to provide them with support and care. The second point is that states are obliged to immediately pursue all appropriate means of eliminating gender-based violence. So what are a few key concepts to consider in this area? The first is that where gender-based violence prevention and response services exist, they are often implemented on a pilot basis and not scaled up. They are piecemeal and not integrated into existing platforms. And further, intersectoral coordination is often weak. Support and care for adolescent girls who experience intimate partner violence and sexual violence need to be integrated into sexual and reproductive health, HIV, mental health, and adolescent health programs and services. The second key concept to consider is that many healthcare providers are not prepared to deal with gender-based violence, including on the reporting of sexual abuse. Training and ongoing support to healthcare providers are imperative to ensure that care is child and adolescent-centered, age-appropriate, responsive to the needs of adolescents, and takes into account their evolving capacity in decision-making about involving parents and other caregivers. The final point of key concepts to consider is that adolescents often do not seek gender-based violence prevention, support, and care services. Thus, raising public awareness on the signs, symptoms, and health consequences of intimate partner violence and sexual abuse, and on the need for them, and overcoming stigma is key to changing this situation. There are a few key guidelines from WHO that provide recommendations to support programs and policies on gender-based violence, prevention, support, and care. One of the key guidelines is titled Responding to Children and Adolescents Who Have Been Sexually Abused, and these are clinical guidelines. Another is titled Responding to Intimate Partner Violence and Sexual Violence Against Women, WHO Clinical and Policy Guidelines. A third is a section of the WHO Guidelines on Preventing Early Pregnancy and Poor Reproductive Outcomes Among Adolescents in Developing Countries. This guideline is adolescent-specific and includes a section on preventing violence against girls. Another is WHO Guidelines for the Health Sector Response to Child Maltreatment, which is focused more broadly on child maltreatment than just gender-based violence, but also has recommendations that are relevant to this area. And finally, there are a few relevant recommendations in the Consolidated Guideline on Sexual and Reproductive Health and Rights of Women Living with HIV. As we've mentioned in the previous modules, all of these guidelines are available on WHO's website, and most, if not all of them, are available in multiple WHO languages, including French and some in Arabic as well. In addition to those key WHO guidelines, there are also some complementary documents to WHO's guidelines that we would recommend you all have a look at if you're interested in this area of work. For example, there's a global plan of action for health systems to address violence against women and girls, which was published by WHO in 2017. There's the Respect Framework, which is a terrific resource on preventing violence against women. It includes a framework as well as an implementation package and was published just in 2019 by WHO. This would be a really interesting one for you to look at. Next is the Inspire package of 7 strategies for ending violence against children, which is also a really valuable resource published by WHO in 2016. Fourth is the Global Guidance on Addressing School-Related Gender-Based Violence, published by UNESCO in 2016. There's 16 ideas for addressing violence against women in the context of the HIV epidemic, which is a programming tool published by WHO in 2013. Then there's a package of resources, including this evidence review from What Works to Prevent Partner Violence from London School of Hygiene and Tropical Medicine. This resource was published in 2011. And then there's a School-Based Violence Prevention Practical Handbook published by WHO in 2019. Finally, at the bottom of the slide, you'll see 3 resources that are in blue, and these are all specific to the COVID-19 context. The first is COVID-19 and Violence Against Women, What the Health Sector System Can and Should Do, published by WHO in 2020. Another is titled Addressing Violence Against Children, Women, and Older People During the COVID-19 Pandemic, Key Actions, again published by WHO last year. And then finally, there are a set of infographics on COVID-19 and violence against women published by WHO in 2020 that can be really useful advocacy tools for spreading awareness of this area. Again, these are all available in the public arena, and many of them are available in multiple languages. As usual, we have a small cartoon depicting a common situation that you might run into in a clinical scenario. Here you have one of the health workers saying her partner has hurt her, should we send her to the police station, referring to a woman who has come with presenting signs of some kind of gender-based violence. and one of the older supervisors or health workers accompanying the other health worker says, "Let us care for her first. We can then discuss various options so that she can decide what she wants to do." We'll end this global portion of the presentation with a few words on addressing gender-based violence and violence against women and girls, specifically in the context of the COVID-19 pandemic. We mentioned a few resources on one of the previous slides. In addition to those, the Not on Pause technical brief published by UNFPA last year on responding to the sexual and reproductive needs of adolescents in the context of the COVID-19 crisis also includes a section on gender-based violence. In terms of specific measures for delivery of gender-based violence, prevention, support, and care services in the context of COVID-19, it presents a few recommendations as shown on this slide. The first is to inform adolescents where and how to get care, where access is possible, through mass media and digital media. The second is to sensitize and alert healthcare providers, community workers, and support networks to the potential for increases in sexual and gender-based violence, and to ensure that they are aware of adolescents' specific vulnerabilities, for example, their limited ability to report abuse. The third point is to strengthen screening and enhance care and support, including mental health and psychological support for adolescents. The fourth is to ensure the availability of post-rape care services, including emergency contraception, HIV post-exposure prophylaxis, and testing and treatment for STIs for adolescents. The next is to identify safe houses, shelters, or social services, referrals for adolescents at risk of violence in or around their homes. And the final point is to establish helplines or enhance existing helplines for adolescents to seek help if needed. The technical brief Not on Pause also provides two considerations for the resumption of normal services in the context of COVID-19. These are to inform adolescents that they can seek care if they have experienced sexual and gender-based violence and were unable to do so, that is, to seek care during periods of confinement. The second point is that where possible, promote the institutionalization of good practices in improving accessibility and quality that were put in place during the period of closures and disruptions. That brings us to the end of the global segment of this presentation. I hope you found it useful, and from here I'll turn over to my colleagues from the Eastern Mediterranean Regional Office. Thank you.
Welcome everybody to Module 7 on violence against women and girls, prevention, support, and care. I want to express my thanks and gratitude to HQ colleagues. Thank you for sharing the global data and information. My name is Untitled Ronzoni, and I am the Gender-Based Violence Technical Officer at WHO Regional Office for the Eastern Mediterranean, from Department of Healthier Population, Violence and Injury Prevention and Disability Unit. And I will accompany you in this session on the regional perspective on violence against women and girls in terms of prevention, support, and care. Violence against women and girls is a global issue. Worldwide, 1 in 3 women will face gender-based violence in their lifetime. In this global scenario, the Eastern Mediterranean region has the second highest prevalence, with an estimate of 37% of heavy partner women experiencing physical or sexual intimate partner violence at some point in their lives. Adolescent girls, young women, women belonging to ethnic and other minorities, and women with disabilities face a higher risk of different forms of violence. Available data from countries in the region on SDGs indicator 5.2.1, proportion of ever partner women and girls aged 15 years and older subjected to physical, sexual, or psychological violence by a former or current partner in the previous 12 months show a very high prevalence in many countries, many of them also facing humanitarian emergency. Data available from Demographic Health Service in the countries, as we can see in the slide, show high prevalence of violence against women and girls, 52% in Afghanistan, 29% in Palestine, 27% in Jordan, 25% in Pakistan, 24% in Egypt. And if we go deeper into the data, we see that in Afghanistan, almost 90% of women have experienced one form of domestic violence, and 52% have experienced physical violence, and 70% have experienced sexual violence. In Somalia, 37% of women. So it's a very high prevalence that we are talking about. From a policy perspective, the Sexual, Reproductive, Maternal, Newborn, Child and Adolescent Health Policy Survey 2018 and 2019 highlighted that the EMR has the lowest proportion of country, equal to 53%, with national multi-sectorial plans of action for violence against women, if compared to other countries globally. However, of the 16 countries that responded to this policy survey in the region, 81% cited adolescents as a specific group for defined intervention for gender-based violence, and 88% responded to have a law to punish perpetrators of coercive sex involving adolescent girls. Nevertheless, as we will see in the next slide, access to services as well as implementation of the law to ensure the punishment of the perpetrator of sexual violence still remained a challenge in this region. Talking about challenges, the EMR region faced many challenges at different levels of the society and within the health system. For example, high rates of child and forced marriage, which apart from being a violation of human rights, increase dramatically the risk of exposure to many forms of gender-based violence, particularly domestic violence. Therefore, there is a need to work at community level to increase awareness of traditional institutions, community and religious leaders, and government actors to systematically address this issue. Underreporting is another prevalent issue in our region. Due to fear of social stigma, bring dishonor to the family, and fear of retaliation, women and girls hesitate to report incidents and believe that nothing could be done. They are commonly afraid of further violence from perpetrators, and they may not trust services due to fear of confidentiality breach. Another important issue in our region is that at the same time, awareness at community level is very much needed to change harmful and negative attitudes and social and cultural norms that blame women and girls for violence they are experiencing, along with gender discrimination and stigma. Society often prefer prioritizing protecting family honor over the safety and well-being of survivors, and encourage institutional and social acceptance of violence against women and girls as normal, which means that many women and girls won't identify many harmful behaviors as violence because society sees them as normal and therefore accepted. We can see the effect of these harmful attitudes and normalization of violence in this slide, where are highlighted both the proportion of males 15–49 years old who consider a husband to be justified in hitting or beating his wife, and the proportion of female 15–49 years who consider a husband justified in hitting or beating his wife. For example, this percentage in terms of male considering husband to be justified in hitting his wife is 70% in Afghanistan, very, very high, 64% in Jordan, 58% in Pakistan, and 22% in Qatar. And when we look at the proportion of females who consider husband justified hitting or beating his wife, percentage are even bigger. In Afghanistan, for example, 78%. Another set of regional challenges are highlighted in this slide, and among them, lack of information, which means limited information is available to the public regarding the consequences of gender-based violence and the availability of potential legal and social support services for the survivors. Apart from the lack of information on where to go, the scarcity of specialized services for women and girls survivors of violence constitute another challenge in the region. Women and girls who experience violence against women are likely to seek family planning or maternal health services. Therefore, the health sector is one of the key entry points for ensuring survivors can get the care and the support they need. Unfortunately, these services are often non-available. For example, a recent survey showed that only 10% of facilities in Afghanistan are well prepared to address gender-based violence, and that only a quarter of the 280 health facilities survived in 7 provinces had a private examination rooms, and only 2% of facilities had a protocol in place for GBV care. These are all barriers that really can compromise access of women and girls to health care. Also, and finally, as already anticipated, the EMR faces more humanitarian emergencies than any other part of the world. That increases the risk factors and creates extra challenges for preventing and responding to violence against women and girls, and can bring new forms of violence. Data is limited, but research suggests that approximately a fifth of refugees or displaced women in complex humanitarian settings have experienced sexual violence. At the same time, care services for women and girls survivors of violence remain on the less implemented parts of the minimum initial service package, also known as the MISP. To address all these challenges, many of them linked to the lack of community awareness and cultural harmful norms and attitudes, there is definitely a need to intensify the work at community level through, for example, community awareness. This is why we decided to bring one successful example of this kind of activities in this course. And we are talking about the Violence Against Women Awareness Campaign in Afghanistan, conducted between 2016 and 2017 by Public Legal Awareness Unit of the Afghan Ministry of Justice and 2 local NGOs, which are Women for Afghan Women and Voice of Women organization, with the support from the International Development Law Organization. The campaign was implemented across 9 provinces of the country, including hard-to-reach areas, and was able to reach almost 5,000 people. And the aim of the campaign was to educate communities on all forms of gender-based violence, including domestic violence, forced and underage marriage, rape, forced prostitution, beating, harassment, humiliation, and other forms of gender-based violence. The campaign included different types of activities, as you may see from the pictures in this slide. For example, signing a symbolic pledge banner where students, including male, because also engagement of men and boys is very important in reducing violence against women, where the students affirm their commitment to say no to violence against women, or public awareness on citizen rights so that everybody is informed about the rights they have and maybe they don't know to have because of lack of awareness. High school teachers were also empowered to raise awareness locally within their school, and we know how much it is essential, the role of education in tackling harmful stereotypes and norms. Also, local ownership helped ensuring the sustainability and success of the campaign. And different types of activities to engage all the ages of the population, such as live drama performances, to engage young audience, but also activities directly addressing community leaders who were familiarized with constitutional and religious legal framework to ensure that decisions are fair and consider the rights of all parties. But there is also another component that we would like to address in this session, which is the COVID-19 pandemic. We previously said that GBV is likely to increase during every type of emergency, including epidemics, due to the stress, disruption of social and protective networks, decreased access to services. COVID-19 and GBV are interrelated pandemics because they are both spread all over the world. And the COVID-19 stay-at-home measure, isolation, restricted movement to contain the spread of the infection have had particularly acute impact on women experiencing situations of domestic violence. Surveys conducted by the health clusters from April to May 2020 to measure the health service utilization by GBV survivors during COVID-19 in Afghanistan, Iraq, and Somalia showed a 45% increase in GBV service utilization. And also the survey findings highlighted an increase not only in domestic violence, but also sexual violence against girls, along with concerning upsurge in female genital mutilation. To contrast this, initiative had thus been undertaken at the country level to address continuity of life-saving services and to establish referral linkages in order to connect survivors and reach out to women and girls in need of support. In order to address the effect of COVID-19 on the risk of increased gender-based violence, some of good practices were put into action in our region and are highlighted here in this slide. For example, in Afghanistan, a guidance note was developed for women's protection centers operating during the COVID-19 pandemic in partnership with UN Women to make sure that women who are hosted in protection shelters are not only safe from violence but also from COVID. In Iraq and Lebanon, to address the challenge related to the lockdown and the stop of many services in present and guidance was produced for both remote and face-to-face health services for women who may have been subjected to violence, and also referral pathways have been updated. Very important also, an online training was conducted on GBV and COVID for frontline workers from Ministry of Interiors and Ministry of Defense that were responsible to ensure social security and respect of lockdown measures. And on the same line, in Pakistan, GBV specialized telemedicine support and health services were implemented in collaboration with the Institute of Psychiatry in Balochistan. And also the integration of GBV consideration was included in the training of health providers, maximizing therefore the effort and making sure that violence against women services are integrated into the COVID-19 response. Coming to the key messages, we always need to remember that however many risk factors can increase the exposure to GBV, specifically perpetrated against women and girls, this kind of violence is largely driven by deep-rooted gender discrimination and constitutes a significant threat to adolescent health and well-being in the region. To mitigate the effect and the health impact of such violence, health services are critical, particularly when it comes to prevent HIV, unwanted pregnancy, sexual transmitted infections, and adverse mental health outcomes. Unfortunately, health services for women and girl survivors remain inadequate in many countries in the region, with severe consequences for the health and security of women and girls. Therefore, WHO is intensifying its effort to ensure that violence against women and girls is better prioritized by the health sector in emergency, and that health partners are equipped with the technical knowledge needed to respond to it. WHO is also working to encourage donors, UN agencies, and NGOs to step up efforts to integrate services for women and girls survivors as a core part of the health response in emergencies, including for COVID-19. Keeping in mind these messages, we can work to enhance quality of care and access to GBV services to women and girls in our region. And with these key messages, I thank you for your attention and I leave you with the next slides on available reference for further consultation. Thank you so much.